And my elders, sisters, and dear guests, Salamun alaikum wa rahmatullahi wa barakatuh. It's my great pleasure to welcome you all to our online ladies event run by the Al Mahdi Health Committee. My name's Zainab, and inshallah, alongside Sister Masma Huda, we'll be acting as the MCs for this afternoon. The topic for today is conception, pregnancy loss, and maternal mental health. Topics that are relevant for so many of us. And especially today, with it being Mother's Day, we thought we'd take the opportunity to explore some of these issues that don't really get the attention and the platform that they should. So with the help of our guests today, inshallah, we aim to unpack these issues from both a medical and an Islamic point of view, with the hope that this will provide us all with both some information and reassurance. So in terms of the format for today's event, our first talk will be a medically orientated talk and will then immediately be followed by an opportunity for you to ask any medical questions on these topics for our speaker. And this will then be followed by a second talk covering some of the more Islamic and spiritual aspects of the discussion, followed by a further 5 to 10 minutes of a question and answer session. So to ask your questions, you can visit slido.com and use the event code 165476. And we'll just put a banner up at the bottom just to let you know what the code is. And this will allow you to ask any questions anonymously. The platform is open for you to use from now, so please feel free to log in and post any questions that you might have. We want the event to be interactive and personal and cater to your needs. So please do take the opportunity to ask any questions that you may have that want to be answered, inshallah. Without further ado, Sister Masma, I'll pass over to you, please, to introduce our first speaker.
Assalamu alaikum. Thank you, Zainab, for the introduction. I would like to now introduce the first speaker, June. Dr. Juneida Khodabocus is a specialist registrar in her 5th year of training in obstetrics and gynecology in Wessex in the UK. Originally from Mauritius, she graduated with distinction from King's College London in 2015. Her areas of interest include laparoscopic surgery, endometriosis, and high-risk obstetrics, including obesity and pregnancy. An amateur baker who enjoys calligraphy and scuba diving, Juneida is also an ambassador for the international NGO, the PAD Project, promoting menstrual equality globally. Her life motto is, "Even a tiny step forward is a definite step." I will now pass it over to June for her talk.
Okay, Assalamu alaikum everyone. Thank you so much for giving me the opportunity to talk to you about this topic. And as Zainab said, it's actually a good day, being Mother's Day today, to talk about these subjects, which I found has quite a few misconceptions, especially from a Islamic point of view. However, I hope I can enlighten you a little bit more on these 3 topics, and I'm happy to answer any questions as well. Without further delay, I'm just going to start the presentation. So, regards to conception, the other word that we can use interchangeably for it is infertility. And it's actually more common than we actually think. Around 1 in 7 couples initially have difficulty conceiving. And what do we actually mean by infertility is when a couple is trying to conceive, which means getting pregnant, with regular intercourse, having no form of contraception. And if over a year of trying, they haven't been conceived, that's deemed to be infertility. However, it's reassuring to know that because we know around 84% of couples will actually conceive naturally within a year, and within 2 years, up to 90 to 95%. Okay, and when we say about regular unprotected sex, we actually advocate for around 2 to 3 days a week. And how do we actually diagnose it? Is if after 1 year of trying, the couple has still not been able to fall pregnant. And we broadly divide into 2 types of infertility. There's one called primary infertility, is when the lady has never been able to conceive a child, as well, it could be in the man as well. And secondary infertility is if you've had 1 pregnancy before, but now this there's some difficulty in conceiving again. And the causes of both primary and secondary are different. We'll talk about it in a minute. And regards to especially primary infertility, we're talking about ovulation disorders, such as a condition called PCOS. We also have some hormonal imbalances as well. It could be age related, because as we grow older, the quality of our eggs as well decreases, and hence there's a increased risk of having difficulty of falling pregnant, and it's a risk of infections. So if you've had any sexually transmitted infection in the past, that can impact on fertility. And also if you've had any form of fibroids, polyps inside the womb, again, that's sometimes can contribute to having difficulty conceiving as well. In the men, the number one cause is usually something called varicocele, where it's just an extra, there's some difficulty in terms of blood flow. So can talk about this a bit later. So these are the main causes. And risk factors being like, if you've got it, so that puts you at increased risk, and sometimes you can actually modify these risk factors. Some of them are non-modifiable, but we do know that with age, as I said, so we say the peak fertility is around like 25 to 26 years old, and usually after that doesn't mean because of the quality of your eggs is going down, so slowly afterwards it becomes a bit increasingly difficult to fall pregnant. We also know that weight, so if someone has a BMI of over 30, for instance, we would strongly advocate for them to lose weight and to try, and that's to do because excess fat can also cause a disruption in the hormonal cycle, hence difficulty to ovulate, that is releasing an egg every month, hence difficulty to conceive. You have some sexually transmitted infections, especially chlamydia, which is asymptomatic. And smoking is a big one. So we do know that smoking, especially in both men and women, can affect. So we do strongly, again, encourage people to stop smoking, and we offer them support. Alcohol mostly affect the quality of sperm, just to be aware, and other environmental factors as well. Certain jobs can put people at risk, like farmers being exposed to pesticides, or like other like miners and stuff being subject to solvents and metals again. And stress is a big one. We do know that stress can cause quite a lot of issues, and the way that we link it to fertility is sometimes, and I've seen it a lot, especially in couples trying to fall pregnant, and there's the extra stress from the family. Oh, why have you not been able to have a child? So all of this put more pressure on the couple, and that can affect their mood, that can affect their libido as well, but also all of these stress can affect the hormonal cycle of the lady in the first instance as well. So this is how it's linked. It's been suggested before, like certain drinks, like caffeinated drinks, tea, coffee, are associated with infertility problems. So nowadays there's been quite a bit of research done to it. So we say there's no real evidence, but if someone is trying, we would say to limit like a coffee to 2 to 3 cups a day. That's just one thing. And the research is still being done on that. And if we look at the causes, as I said, there's different one that we spoke about already, but there is also one big one called unexplained infertility. And if you look, it's around 10% in female and more than that in men. And overall, it contributes to 1 in 4 cases of infertility. And in the younger age group nowadays, I have found, especially in clinics and stuff, that even people out like 27, 28 with medically fit, they've had different investigations and nothing has come out of it explaining why they are having difficulty conceiving. So if that's the case and they've been trying for more than 2 years, in the UK this couple is actually eligible for IVF if they've never had any child before. So now that's one thing, is you might be trying and you'll be like, when do I actually need to get help? So we usually would say, if after trying for 1 year of unprotected intercourse, then you should be seeing your GP. And if you are actually a bit over the age of 36, we would recommend that you see your GP slightly earlier, maybe around 9 to 10 months. Why? It's just because nowadays it's so difficult to get an appointment with a GP, to get referred to all of this, just putting the time pressure into account. So what will the GP actually do? They will do a very quick initial assessment, and they might ask your the partner to come in as well, so to see them as a couple, ask them questions, and then they might take some tests. So what tests are we talking about? So for the ladies, usually we do some blood tests, checking the various hormone level. So you don't need to remember this, but it's like the FSH, LH that we usually measure if the lady is actually ovulating. So this is a preliminary blood test. We would also do an infection screen to make sure there's no infection. So namely the chlamydia test. We can do an ultrasound scan, and by that we're checking for any fibroid, any polyp, or anything like that that can be explaining. We can do something called an X-ray as well, and that's mostly to do where, I don't know if you can see it in the picture here, is we inject a dye which goes in through the womb and to check if the tubes are patent, meaning open, and then we have an X-ray at the same time. So that demonstrates if the tube is blocked or anything along those lines. If someone is suffering from conditions like endometriosis, which is on a topic itself, where basically it's little cells are causing pain and bleeding inside the tummy. So we usually offer something called laparoscopy, which is keyhole surgery. So we go inside the tummy, have a look, and check if the tube's working or if there's any other issues that could explain why there's a difficulty conceiving. For the male, usually we would do something called a semen analysis, where they give us a sample of the sperm. And if you can see on the right side of the picture, these are just like 1 ml of sperms under microscope. And we check different things, so the quality of the sperm, the motility, like how fast they're going and how healthy they are. And we also do chlamydia tests, like checking for infection for the male. And with regards to treatment, again, there's different treatment. For medical, we will give some medication called clomiphene that helps to encourage ovulation. In the treatment of PCOS, we can usually sometimes use metformin, and there are also other medications that we can help to stimulate the gland in the brain to start to release certain hormones to help. But otherwise, you have surgical treatment where if you go in on the left side of the picture, if you see these, there's a womb, a big picture of the womb, and then on the left side, there's like a tube a bit enlarged and a big cyst. Sometimes that can impact ovulation, and there's loads of adhesion as well. So sometimes we remove these by keyhole. If there's a big fibroid, we can remove it. And if there's a big ovary, we sometimes drill it just to release the pressure on it to help release of the egg. For the male, sometimes there can be some blockage with regards to the tube that brings the sperm from the testes up. So therefore, what we do, we can sometimes do some corrective surgery for that, or we can even just go in with a syringe and extract the sperm, which we can use then for IVF. And there's another, coming to the topic of IVF, there's something else called assisted conception again. We can do it two ways. If, for instance, we do know that there's a problem with the quality or like the motility, which is like the speed at which the sperm is moving up, we can inject it straight up inside the womb, as you can see in the left picture, and that's called intrauterine insemination. But if there's no issues, if there's a difficulty with that, we can do something called IVF, where it's a whole process in itself, and as you can see, that requires careful monitoring, and obviously in a specialist center. We pick up the egg, we use the sperm, we fertilize it, and then we implant the embryo inside the womb. And again, that's with loads of monitoring from our side. So this is just the first part. I hope I'm doing okay for time. With regards to pregnancy, I know it's a bit quick, guys, but it's a very brief overview. I'm happy to take questions at the end. So pregnancy, loss, or miscarriage is actually much more common than people actually think. Like 1 in 4 pregnancies end up in a miscarriage. And when we say miscarriage, is the loss of a pregnancy during the first 23 weeks. But most miscarriage occur within the first less than 8 weeks. And a lot of them actually happen before the lady is actually even aware that she's pregnant. So sometimes some people might be having a very, very heavy period and they might actually be miscarrying and they don't realize it. So what the most common sign of miscarriage is actually bleeding. And but you can also get some cramping, but loads of people kind of like think they are having like a crampy period pain. You can have some discharge, of fluid or tissue, and sometimes some people tell us they don't no longer experience any symptoms of pregnancy, such as sickness, vomiting, or any breast tenderness. But the most common one is definitely vaginal bleeding. And as I say, the most common one, first trimester, we tend to divide it, is less than 12 weeks. And that's to do with the problem at the level of the chromosome itself. So the genes of the baby itself is not compatible with life. Hence, we say nature takes its course quite early, and then the pregnancy just miscarries. Sometimes there can be issues with regards to the placenta. So the placenta is the tissue that is going to be the feeding ground for the baby, and as an intermediate between the mother and the baby. And sometimes there's a problem with regard to that. And again, certain things like age, for instance, if you are like 25, your risk of miscarriage is only around like 5 to 10%, whereas if you go more than 35, it increases to 25%. So there's different age data for that as well. But obesity as well, smoking, alcohol, and recreational drugs strongly associated with miscarriage. And second trimester is mostly 12 to 24 weeks, and that can actually have more impact on the lady as she's been pregnant for a bit longer and has developed a certain bond with the baby. But these are mostly long-term conditions such as diabetes, blood pressure, kidney or thyroid problems, one of them. And antiphospholipid syndrome is one to do with the bloods in terms of being clotty, and that's actually one of the major causes of recurrent miscarriage, where you can have different infections as well. And I'm just going to go very quickly on that. There's food poisoning, certain medication. That's why we certain food like cheese and stuff that we do say to be careful in pregnancy. Certain raw, like salmonella, is one to cause some issues as well. But there are different medications. So if you have certain conditions like rheumatoid arthritis or even like blood pressure and stuff, we usually would recommend that we see the patient before she tries for pregnancy, so we can adjust her medication and make sure she's on the right medication before she falls pregnant. And there's something again with a certain womb structure or like the cervix being a little bit weak. And again, there are a few misconceptions that I think I need to, because I hear a lot of this, especially in Asian ladies coming in and saying like this, being super stressed or depressed, that's why you've had a shock, exercise, heavy lifting, or like having sex during pregnancy, working, all of this, and one of them being eating spicy food. All of that, it's not related at all with miscarriage, just to be aware. And how do you actually diagnose it? The number one way is to actually do an ultrasound scan. And if you see here, there's a picture. If usually we put like a Doppler, which is a color, so anything with blood flow will reveal itself. Like here, you can see on the lower side of the picture, the womb has got the blood flow, but the pregnancy inside the womb itself has got no blood flow at all. So sadly, this is a miscarriage. And what do we do? How do we treat it? You can just wait and watch, and nature will take its course. Sometimes you can give some medication to help expedite the delivery of the products, we call it, or sometimes we do a surgical procedure where we use a small suction curette tube to go in and empty the womb, as you can see in the picture here. Recurrent miscarriage is actually a bit rarer. That's 1 in 100. And that's defined as 3 or more consecutive miscarriage, and they have to be with the same partner. And we will only investigate miscarriage when there is 3 or more consecutive one, because as I said, it's quite common for various reasons. So if you come in with 1 miscarriage, there's no actual need to investigate. And why do we say that? Even with 3 or more consecutive miscarriage, we do investigate. But even then, there is still more than 75% chance of having a successful future pregnancy afterwards. And the investigation will involve the blood test. We look at the products as well that we take, especially if we got it at surgery. And then we will send it to the lab to check if there's any chromosomal issues, and we also check the chromosomes, the genes of the parents, to see if there's an incompatibility. And afterwards, obviously, there is a huge emotional impact with regards to that. There's anxiety, support, and usually that's where I'm hoping Sister Nasim will help us. And I think that's very important from a Muslim community to offer that support. And we all ideally say you can try to conceive whenever you're ready, but ideally after miscarriage, if you wait for one normal cycle to restore itself, so then after that you can start trying whenever you're ready. I'm going to very quickly whiz through that. I know I'm running over quickly, but in terms of maternal health, are you happy with that, Zainab? Can I just quickly run through that? So in terms of maternal mental health, there is something called baby blues, which is really, really common. And you have depression, anxiety, or psychosis, where you have hallucinations or delusions. So up to 1 in 5 ladies will suffer from mental health after postpartum, after having a baby. 15% of them will actually require treatment. And as you see, there are more than 100,000 persons a year suffer in silence of this. And this is not something that should be actually happening. That's why we're here as a community as well to offer support to this group. And just to look at it, like baby blues is really common, and it occurs within the first 2 weeks of birth. And that's just feeling because your role has changed, your sleep pattern has changed, you're tired all the time. And this is actually really common, and no treatment is actually really needed for that. But depression is a little bit longer. If you go here, for instance, if you just look at this, depression is the one that will actually require treatment sometimes, and it's a bit more serious. But again, people tend, with the right support, they tend to overcommit. But psychosis is one which is quite rare. It's 0.01%, but it's very, if we don't pick it up, it can be devastating, because the patient had a patient thinking that the baby is in danger and trying to protect the baby, actually causing more harm to the baby. And there are different risk factors for that. Again, if you've had a previous mental health illness in the past, your work environment, your support, if you're a single parent, and there's different aspects as well to go to that. And treatment, again, usually first line would be counseling, talking, medication can be, but what I've found is a good support in terms of friends and family, exercise, sleep, and just some help is actually what does the trick. And then some evidence as well, some people use acupuncture, massage, and chiro, but I think that's more to do to like dealing with the stress and being able to manage it. That's it. I think I'm overrun for a few minutes. I'm sorry.
No, that's completely fine. Thank you, June, so much for such an informative talk and for covering the topics that you have, and also especially the stigma associated, especially with IVF. And your statistics have really shown how common infertility and pregnancy loss is. So we'll now just move on to the Q&A.
Yeah.
So I have a question here. Someone has written in, with PCOS, does the fertility depend on how often you have your menstrual cycle? Can you ovulate without having your cycle every month? And this person's mentioned that they have it every 6 months.
Yeah. So PCOS is one of those conditions which is quite tricky to actually treat. And so to be able to fall pregnant, you have to ovulate, because it's the egg that will be fertilized by the sperm to create the pregnancy. So if you're not ovulating, unfortunately, you're decreasing your chances. And if you're having an ovulation only like once, twice a year, that reduces the chance compared to having every month. That's why we do. So then the thing is, you see the GP, and usually the first line we can give something called Clomid, and then Clomid will try to regulate. Sometimes just being on the pill as well, they try to regulate the cycles initially, but Clomid is what will help ovulate it. But again, it's very difficult for me to give advice just like that, because we have to do a tailored approach, and that's why the GP is the first person in place.
Okay, thank you.
Yeah.
Thank you so much. So June, there's another question here. So conceiving after a loss can be a very daunting experience. Are there any practical tips you can provide to maintain this pregnancy zen, especially when reaching certain milestones?
Yeah. So this is something I see, like, really, really often. And again, we say after, it's like when you are also ready from a mental health point of view as well, to try and having the good support to try for another pregnancy. And usually from a medical point of view, we would say to wait for at least one cycle. So we know that's when your last period was, so we can track the pregnancy better. But then once the patient is pregnant, we would usually, if they're usually incredibly anxious, and they can come in, and usually we can offer an earlier scan, because we have the earlier scan any women with no issues will be at 12 weeks and 20 weeks. But if they're coming in and they found out that they are 6-7 weeks, often like doing a scan early put them incredibly more at ease, and we just monitor them, and we are available for any advice as well.
Okay, great.
Thank you.
I just have another question here. I know you touched on this in your talk. How can we recognize postpartum depression in our friends, family, and ourselves? I know you mentioned a lot on ourselves, but what about if a family or friend has gone through something? Are there any signs that we can pick up on to kind of recognize if they're going through this? And where can help be sought for this?
Yeah, so it's like you will see usually the 3 classic thing of depression is like reduced energy level and reduced mood, and also not enjoying things that they used to enjoy before. I don't know if they always enjoyed baking, or they always enjoyed going for a walk, and now they're like, no, I don't want to do this anymore. So they also have this feeling of helplessness, hopelessness, or even worthlessness. Oh, I'm not actually a good mom at all, I can't do this. Or like, whatever I'm trying, this baby is not actually feeding, it's not. So it's all little things. But that's why sometimes baby blues, it's common, we all have a limit, but it's like as to when it's going on for too long, so it's impacting on the patient, so then they are a bit late all the time. So you will notice a difference in the way that they are talking to you, so therefore, and the best thing is actually to talk to them and ask them very honestly, how do you feel you're coping? How are you feeling? Is there anything we can do? Do you want me to just come and look after the baby for an hour so you can have a bit of rest? Or do you want me to cook for you? Do you want me to, like little things like that, do laundry? I mean, my cousin sister had a baby, and these little things, sometimes just going in and just cooking, washing, and everything for her, so she just can enjoy and sit down, because while she's breastfeeding, she's thinking of a million other things to do, where she could actually be enjoying that moment.
Yeah.
Yeah, thank you. That was really beneficial, actually. Really good to know. Yeah. Another question here. How long does it take usually to conceive again after a miscarriage or a stillbirth?
And again, usually we say it can be super quick, or there's no statistics on it. You just try and see and wait. And especially the thing is, if you've had a miscarriage, in a way, it's like you can fall pregnant, so it's not infertility here that we are dealing with why are you not able to grow that pregnancy. And again, the first pregnancy, especially if you've had it as a miscarriage, is incredibly common. So afterwards, even if you've had 3 miscarriages in a row, after that there is still a 75% chance of having a normal successful pregnancy. So the idea is we just need to keep trying, but whenever you're ready.
Lovely. And so, sorry, just a quick follow on from that. So if someone has had a miscarriage, are they more likely to then have another subsequent miscarriage after?
So not necessarily. However, if now we tend to look at it the other way around. If someone had a miscarriage, like 3 miscarriages in a row, then we are thinking there might be an underlying issue. That's when we're going to investigate. Because with just 1 miscarriage, it's difficult to investigate, because it's a bit like putting this lady through so much investigation, through much pressure for no reason. Or I would tend to, because there are some conditions like antiphospholipid syndrome, where there's a clotting disorder of the blood, and then so we pick it up after. We tend to do the other way around. If you get what I mean, yeah.
Yeah, thank you.
This question sort of leads on to that as a little bit. So if once you've had a pregnancy loss, from a medical perspective, how can we improve the aftercare?
So the aftercare. So again, if someone, we usually say, like if a patient comes in having had miscarriage, that we will obviously take a history, asking them a question about their lifestyle, their weight, and their age. Age obviously is not a factor that they can modify, but their weight, for instance, we will try to make them go into the normal BMI, which is between 18 to 25, stop smoking ultimately. And now if they already have some underlying conditions like high blood pressure or diabetes or anything along this line, we tend to optimize them. So make sure the blood pressure is very well under control, the diabetes under control, everything is like to the optimum before they try to conceive. We have patients with epilepsy, for instance, they come in and some of the medication, anti-epileptic, is going to be detrimental to the baby's progress in terms of birth. So what we do is we see them before they want to conceive and we change the medication to the one that's safe in pregnancy.
Okay, great.
We have quite a few questions coming in. I think just in the interest of time, we might just stick to the last two, I think. So just the second last question. So if someone has had 3 miscarriages, do the statistics change in a sense that why do then they need to be investigated rather than anyone, for example, having 2 miscarriages?
Yeah, so because again, that's been done on previous studies, and we found out that it's like the 3 is the cutoff, and again, and even there's arguments saying, some people say, even if you investigate them, we don't find anything, what do we do to get up? So therefore, and again, then we still encourage them, but to try. But if you investigate and you find an issue, like if you find that they have antiphospholipid syndrome, we can give them some medications like aspirin, we give them some injections to basically help to optimize this pregnancy throughout. But the stats is very difficult to go exactly, but that's based on like evidence, and that's the national guidelines.
Sure.
That we use. In regards to weight gain, here I see a question about weight gain. There's nothing about weight gain or whatever through miscarriage. Okay. Usually, again, that's because sometimes the people are depressed, and which is understandable, and then they end up they're not as active, they are eating a bit more, stuff like that. It's nothing to do with the miscarriage itself.
Sure.
Yeah.
Thank you so much. Thank you.
And I think the other thing is, if you've had just one, I think that's a very important question about having gone through depression with my previous child. Actually, that puts you at increased risk of having depression in this time. Okay. And actually, it's very important that they talk about it, are able to feel comfortable talking, especially to the husband, to the family, so that they have more support available, because it tends to become a bit more severe as well in the second pregnancy. So therefore, and it's all about support in here, making sure if there's no taboo, there's no stigma around it, but just to give me that support that I need to prevent it. Yeah.
Okay. Jazakallah, June. Thank you so much. That was really informative. I wish we had longer with you.
I know. I feel like that's what.
Thank you so much.
But I would be more than happy to speak if you had any events in the future as well for me to talk about, because I think that's been actually really useful for you.
No, thank you so much. Honestly, It's been such an informative talk, and I'm sure many have benefited from it.
If you can send them my email address. If anyone has any questions, they can more likely to email me, and I'm more than happy to reply then this way as well.
Okay. Yeah? Great. Thank you.
Okay, then Assalamu alaikum, everyone.
Thank you so much. Okay. So inshallah, we will now go on to our second talk.